Our next session is a conversation around the search for biomarkers of ADTKD, which will be moderated by Dr. Sorin Fedeles. Good morning, Sorin. Dr. Fedeles is the Executive Director of the Polycystic Kidney Disease Outcomes Consortium at the Critical Path Institute. Prior to CPAT, Sorin was a faculty and entrepreneur at Yale University School of Medicine, where he led a program focused on identifying new targets and pharmacological avenues for the treatment of autosomal dominant polycystic kidney disease. Sorin, let me turn it over to you to introduce our first panelist and moderate the Q&A. Thank you.
Thank you so much, Sharon. Good morning, everybody, and thanks for the invitation to moderate this session and to be part of the ADTKD research community. It's been wonderful. So the first speaker today is Dr. Greg Papagregoriou, and I'm sure everybody knows Greg. So he's been in the field for a long time. He's got a long track record in making seminal contributions on ADTKD, in particular the ADTKD MAC1 form. He's currently a group leader at the Center of Excellence in Biobanking and Biomedical Research at the University of Cyprus. He has coordinated the first clinical trial involving CKD patients in Cyprus and has led ADTKD MAC1 biomarker discovery efforts. And previously, he was a research scientist at the Center for Therapeutic Development at the Broad Institute of MIT and Harvard. So I'll turn this over to Greg.
Hi, Sorin. Thank you. Thank you for your invitation, Sharon. Well, I don't have some slides. I don't see them. Do you want me to share them myself?
I can pull them up, or if you'd like to.
No. I'll do it myself. Yeah, thank you.
Okay.
Okay. Can you see my screen? All right. So I work at the biobank.cy Center of Excellence at the University of Cyprus, and we've been working for years, especially on ADTKD MAC1. Professor Konstantinos Zelvas, who's a director, together with Dr. Christoforos Stavru, were the two first people that actually published something on what was called back in the day MCKD1. And this is what we do to discover biomarkers. So we do have lots of patients in a cluster living in the westernmost part of the island, Paphos, and they are more than 160 positive individuals here. And we have tested more than 400 individuals, and actually it's quite impressive that 1 in every 580 people that come from Paphos bears this mutation, the C insertion. So what's the strategy? To develop a biomarker that is, first of all, robust and accessible by everyone so that everyone could participate in trials. It should be multiparametric to include all the peculiar manifestations of the disease, which we're still trying to discover what they are. It should have pathobiological relevance and be disease specific, so that it enables the performance of disease specific clinical trials. So we primarily hold an observational study going on. It's longitudinal, takes years, and basically we do follow and register the natural history of the disease. And then through the biobank, we save data and samples in the form of urine, serum, or plasma, where we go back and test for biomarkers, most frequently for urinary extracellular vesicles, which we're trying to establish as a liquid form of biopsy. Try to see if it actually reflects what happens in the kidney without having to go through a needle biopsy if that's ever something to achieve. So let's start from the observational study. This is a standard procedure for cohorts that would undergo a trial, especially for a rare disease as ADTKD, diseases as the ADTKD family. Here we have, again, we do have UMOD patients and Brent patients and DNAGB1 patients as well, 11, sorry. But we're focusing on this MAC1 cohort that we study for many years. So we harvest data, we analyze them, we try to build in silico models that simulate the disease progression, try to identify, as many other of the speakers before me said, the reasons why patients have different rates of progression, and then by describing the natural history, understanding the disease, what happens first, what happens second, what happens next, then try to define what will be the clinical trial endpoints. Then this helps us in biomarker establishment because we bring together data from omics analysis and phenotypes together. And of course, this longitudinal type of biobanking enables the possibility to go back and see how something develops in urine or in plasma. Our observational study includes 46 patients, and we have completed 7 years harvesting a lot of data, a big amount of data. And now we entered the 8th year of this study, and we're quite excited. We also included 29 controls. And by controls, I mean volunteers that are related to the patients, and they live nearby. So in a way to eliminate environmental factors affecting the progression of the disease. So we do have lots of data, as I said, and everything, if you see ADTKDs from a distance, everything looks the same. So what we try to do is take a closer look and delineate the phenotype. So we do try to find what type of what defines progression rates. And here you see some words, but how can you justify if someone progresses slower than someone else, and if this person is eligible to be included in a trial? So we do build mathematical models and data sets using machine learning, and we managed to gather data going back more than 40 years from the patients that we curate, 130 patients. And out of these patients, we built data sets that were then homogenized in a way by following Euclidean distance protocols. And then we proceeded to do clustering classification of the patients to assist in this search for biomarkers. It's better to have good groups, well-defined groups to compare, rather than having a spectrum that it's not easily being characterized. So this is something that I wanted to show. It's how we define the regions in time that we don't really know what happened, because a patient might check in with their doctor at any point in their lives. So imagine that the beginning of the disease, the first years of adulthood are the data are missing from there. So what actually worked after testing a lot of different versions of this is when we overlaid data that came from the controls that belong to this specific region in time, and also data from the biobank in a machine learning, by using machine learning models, and actually created a very, very robust data set that, as you see here, can distinguish between different groups of progression. And we do use EGFR, we use other parameters as well. Urea is one of them. So urea is a non-specific marker for evaluating kidney function, but here there is a percentage of contribution, and it makes every model look better. So we do use it. And here are some results. So you see here that 4 groups in this instance, how EGFR, how the different groups differ from each other as time progresses. And then this is urea as well. And these are other factors like CA15-3, that's MAC1, which we measure in a clinical lab. And then fractional excretion of magnesium has also been an important factor here, according to our analysis, magnesium in general in urine, but not uric acid, which it was kind of an important variable for Cypriots once, I guess. So then after having the models coming up with clusters, we try to do some sort of dimension reduction and then tell the algorithm how these patients are classified in order to do forecasting. That forecasting basically means not only to predict the outcome, but to predict how EGFR, how the renal function would be if we had, let's say, weekly or daily or monthly or yearly measurements. The models will go and tell with high accuracy what the EGFR would be like. So you have a trajectory that you predict, and then this could be overlaid to a trajectory being created by through a clinical trial and aims at reducing the time needed for clinical trials in regards to kidney diseases. Then urinary extracellular vesicles. These are small, really small vesicles, like bubbles of the lipid nature that are released in urine by the cells that process the urine, including the cells that are affected in these diseases. So we harvest them from urine, and we do all sorts of analysis. For example, we do multi-omics, proteomics, transcriptomics, metabolomics, and lipidomics. And it's a good way to achieve personalized medicine because each patient has their own signature, and it also provides information for new druggable targets, new drug delivery strategies, and also their multi-leveled nature brings multiple dimensions in this biomarker development strategy we're trying to follow, so that it's not just one molecule, but there are multiple molecules interacting. Then there is the biomarker assay development, which is quite important since entering a clinical trial. It would be good to have an assay that specifically measures with great accuracy what the end point of the trial would be if that's a marker from the urine, for example. Here are some heat maps from multiple omics experiments from urinary EVs and also from plasma and urine. And these are the same patients, same time point, same urine sample. And it's really effective to have a biobank because you can go back and see how a marker has been developed. Did it increase? Did it decrease? You also have clinical data. You bring everything together, and that's very important to understand and achieve a more disease-specific a way to investigate a disease, and especially, well, this is quite beneficial for rare diseases. We validate the results, try to validate them, come up with a protocol where we isolate rare cells from urine and then do immunofluorescence and see whether protein markers, for example, or pathway markers are expressed in cells that also express markers of tubular epithelial cells. So then it looks something like this. It needs some inspiration and also maybe an artistic kind of view to decide what it's of high importance and not, and then move forward to test it. In the previous years, we did discuss about this biomarker trial that we held some years ago using vitamin D, which was discovered as a molecule that modulates MAC1 wild type and MAC1FS by the Broad Institute. And then we developed an IMRM, that's an immunomolecular reaction monitoring mass spectrometry assay, which we have validated through this trial. And these are some of the results, just to show you that it's quite important to see that each peptide that corresponds to either the wild type or the frame-shifted protein is equally strong, has an equally strong signal, and wild type peptides correlate to each other, while frame-shifted peptides also correlate to each other, but they might not correlate. But wild type might not correlate to frame-shift, and this is okay. These are two different proteins, and this is how measurement looks. Look in the Cypriot and the Wake Forest cohorts, and in the graph, you can also see CA15-3, which was also an endpoint in this biomarker trial that looks much more dispersed compared to urinary EV signals, and it actually is a good way to establish these vesicles as a means of achieving a real-time clinical trial monitor. So searching for biomarkers in ADTKD, it's a really tough, it's a challenge, but then now there are some opportunities which were not, were only something one could imagine a few years ago. There's a regional interest in ADTKD research, and some speakers before me said about the ADTKNet initiative and the European registry, and we are also trying to, we're part of that, but we are trying to be better, more active. There are observational studies being performed. Tony will also tell you, coming right after me, about their efforts. And we have BRD4780 as a leading therapeutics for ADTKD MAC1 and also for ADTKD UMOD, as published recently by Anna's group. And this brings everything closer towards proceeding to clinical trial. Hence, we need a really good biomarker, and this is what we are actually trying to achieve. So that's all from me. Thank you.
Thank you so much, Greg. Wonderful talk. Just to double check, Sharon, so we ask questions after Tony's talk, right? Not now, right?
That's right. Let's have
Okay,
Tony
cool.
go next. Thank you.
Perfect. Thank you so much, Greg. All right, so our second speaker needs no introduction, Dr. Anthony Bleyer. He's our close collaborator right now, and it's been wonderful to work with him the last few months. So Tony, obviously, he's made several contributions in helping identify mutations in UMOD, MAC1, REN, APOE4 as causes of ADTKD. He leads the rare inherited kidney disease research team at Wake Forest School of Medicine, and you know, he's been at it for over 30 years, and you know, we're happy to have him here today. And I'll turn it over to Tony. Thanks, Tony.
Thank you very much, Sorin, who's been a great collaborator. We're really excited to be working with him. And I'm just happy to be here today with everybody in the group. It's just been super awesome to see such a great dedication to this area. There are my disclosures. So just really quick, I'm going to talk about biomarkers. Like, we need a biomarker. It's so important, but it has been very difficult to find. I know that, you know, proteinuria is a great biomarker for diabetic nephropathy. And you can basically, you know, test any of these new drugs for a month and see if the urinary protein goes down, and you have something that will likely be successful. And our lack of a biomarker is causing us to have a lot of problems in moving forward with any treatments. So what is a biomarker? A biomarker is a measurable indicator of a biological state. There are several different types. So there are predictive or prognostic ones that predict clinical outcomes. There are diagnostic ones that aid in a diagnosis. There are markers of disease activity. And so here's a good example. This is what we call the Rampoldi score. And so Luca Rampoldi looked at patients with uromodulin, and he did a Western blot where he reduces it, and you can see a lower molecular weight band here corresponding to the uromodulin precursor in the ER that carries endo-H sensitive and glycans. And then there's a higher weight one, and this corresponds to the more formed one. And you can see that we can develop a mutation score based on this. And the more mature, UMOD that we have, the more that gets out of the cell, then that correlates with better outcomes. And so like these patients here with a grade 4, everything is more stuck in the ER and doesn't get out of the cell. And if we look at our grade 4s here on a survival curve of end-stage kidney disease, we see they have worse long-term survivals. In our grade 1 patients, they have the longest survival. And so we can just take now UMOD mutations and look at them in vitro, and we can determine severity. So this is good for de novo mutations, new mutations, especially in young children or young adults where we want to help out. A prognostic now this is good. It's a predictive biomarker, but it doesn't really change and we cannot really affect it. It's the inherent variant that these patients have. A prognostic marker that's good is, for example, in ADTKD. And here we can look at cyst volume. And this is actually work that Sorin had a great influence in, and CPATH really was very instrumental in. And we can see so here's the kidney volume, and this is low kidney volume, and the kidney volume is going up. And when we look at it, we look at the slope loss of GFR, and the bigger the kidney, the more loss of GFR. And so, if we have a treatment like tolvaptan and kidney size decrease or does not increase as quickly, we can look at that as a marker. So that's really another important thing that we'd like to look at. So that's kind of like intermediate, right? Because we can give a medication, and then after a year, if we had some marker or prognosis, we'd be able to see if it changed. But there are also biomarkers of disease activity, and we'd be super interested in this. So an example would be like the sedimentation rate in inflammatory diseases, or proteinuria in glomerular disease, or potentially fractional excretion of urate in ADTKD UMOD. And so we'd like to, and I always say to our patients, it's kind of like your car has a fuel gauge for the gas tank. And the serum creatinine tells us how much fuel we've used up, right? How much kidney function we've lost. But we want really something like a speedometer that tells us how fast we're losing or the activity of disease. And that's something that we would really need. Biomarkers are critical in ADTKD. First of all, the disease is rare, and we cannot perform long-term studies of large cohorts. So when we look at glucose uptake inhibitors, these studies use 3,000 patients over 4 or 5 years. So we don't even have that many patients to look at. Kidney function changes very slowly in a nonlinear manner over time. And I always say that for the patients, the disease progresses rapidly because they're seeing family members go on dialysis and or needing a transplant, and they're seeing themselves getting closer to transplant. For clinicians, it goes relatively slowly. We see the creatinine stay stable for a year or two, then we'll have a little rise in the creatinine, and it just kind of slowly goes up over time. But for researchers, the progression of disease is agonizingly slow. we have a change in GFR of 2 ml per minute per year, and it just makes it so difficult to study that we cannot really follow eGFR as a long-term outcome in a study. Daily fluctuations in GFR are also a problem. So you're a little more hydrated or less hydrated, and then non-GFR fluctuations in serum creatinine, like if you had a steak or a cheeseburger the night before, you get your creatinine, that can cause variation. And so these are also problematic. So the biomarker depends on the clinical trial that we're going to do. So say we did a trial of a drug that just overall decreased UMOD production, then we would be able to look at urine or plasma UMOD. And a good thing is both of these things are easily measured. We could say have a drug that just decreases mutant UMOD production. So then we will look at urinary mutant UMOD, and this is harder to do and is still subject of investigation. We could also, as one of our speakers mentioned, like the common final pathway is tubulointerstitial fibrosis. So what if we just had a drug that lowers tubulointerstitial fibrosis? And so that would be one of these biomarkers that I'm always perusing journals and trying to find, or biopsy, if we could look at a biopsy of patients before or after, or imaging. So similarly with MUC1, now MUC1 is made throughout the body. UMOD is cleaved by hepcidin and goes into the urine. MUC1 is only in the exosomes or within the cell. It's not cleaved. And I think Greg is looking at these exosomes and doing an awesome job. So again, we could look at, if we overall decrease MUC1 production, we could look at urine or plasma MUC1. But we have to know that it's also made in the kidney and the bladder. So it's what are we studying when we give a drug? Is it decreasing production in both the bladder and the kidney, and how does that affect things? We could look at decreased mutant MUC1 production. This would be difficult if we looked at just the kidney, but if it decreased it all over the body, we could do, for example, biopsies of the salivary glands or the sebaceous glands. Slowing of tubulointerstitial fibrosis, again, biomarker biopsy or imaging. Mutant MUC1, so what are advantages and disadvantages of biomarkers? Mutant MUC1 is present in exosomes. MUC1 is made in bladder and the kidney. Mutant MUC1 is difficult to measure. So this is a tough one. Previously studied biomarkers. So there are a lot of biomarkers that have been studied over time. But when you look at a lot of the papers for these biomarkers, they usually say, this biomarker looks good and it predicts outcome. However, after we adjusted for urinary protein and baseline kidney function, it was no longer significant. We've tested a lot of biomarkers. We're interested in testing more. Imaging. Images is an exciting area. The big problem with this is we can't go back 5 years. We don't have imaging from 5 years ago that's specific, looking at specific detailed mechanisms of imaging. So any imaging studies that we do are going to be difficult, and we're going to have to just do them looking forward. And again, there are different areas of the kidney that we have to look at. The kidney is shrinking over time with this disease. And so we think these are problematic, though promising. Biopsy is also something that could be really helpful. However, there's sampling error with a kidney biopsy, right? We get 20 out of a million glomeruli. There has not really been a good cohort biopsy study. We are actually pursuing this right now. We are doing, so if anyone has kidney biopsies on a number of patients that they'd like to scan and work with us on, this would be really great. And if you could contact us, we'd like to build a big library together. Optimum study is a study that we're working with Sorin on right now. It started September 2024. Our goal is to accelerate discovery of potential biomarkers. And the good thing is, first of all, we've collected a lot of data since 1996, and now we're going to get a lot of statistical analysis. We're going to follow patients prospectively for 3 years. And then we're also going to look at ultrasound and elastography of the kidney. And so basically, we're going to look at kidney stiffness and follow this over time. So biomarkers are specific biomarkers that we see throughout the kidney. And we would think, for example, biomarkers in the thick ascending limb or distal convoluted tubule would be helpful. Here are the biomarkers that we've looked at Wake Forest over time. And unfortunately, we haven't found any that we think are really primed to look at for kidney for a study. We've looked at KIM1, NGAL, TNF, DKK3. You can see just a wide variety of these. So we have a baseline data set of 150 patients, really well phenotyped with lots and lots of baseline urine and plasma. So if anyone has an idea for a biomarker and they're like, wow, we'd like to test your samples, we're so happy to share this with anyone. We looked at KIM1, and here are our patients with KIM1 just looking at their eGFR decline cross-sectionally over time. And we didn't really see anything with KIM1. We were been hopeful that that would work. We looked at MCP1. Again, we did not see anything significant over time with that. So we're really excited about working with Greg because Greg is just looking at everything through a, more like an ohm analysis without any bias. And we'd like to take anything that he develops and hopefully validate it in our cohort, or if anyone else has biomarker ideas, we'd be super interested in working with you on this. Our ALEC, we can look at genetics, demographics, plasma, and urine. So we're very interested to share samples, and here are our many collaborators. But sad to say, right now, we still do not have a really good biomarker of disease activity. It's really kind of hampering our work. And if anyone has any good ideas, we'd love to work with you on this with our samples. So thank you very much.
Thank you so much, Tony.
Yeah.
Wonderful
Let's
talk.
see here.
Um,
Let's see. Am I still sharing?
yes.
All right.
Yes.
Screen sharing. Let's see here. Let's see if I can get out of this. Some reason it won't let me get it out of it. Can you guys just stop the screen sharing? Oh, here we go.
Yeah.
I got it. Stop share.
Yeah.
There we go. Okay, sorry about that.
Perfect. So we have a couple of questions. Actually, Sharon, do you want me to ask the questions in the chat as well?
That's fine if in the Q&A, sure.
Sure. Perfect. So the first one is for Greg first. Have you considered using machine learning algorithms like LSTM, which is a type of neural network that can be applied to higher dimensional data to improve prediction accuracy?
Yeah. I didn't have enough time to show you more stuff, but we are trying to build some sort of a digital twin of MAC1 affected tubules, how they behave, because we don't have all this data now, and there are also data from the literature and also data in freely available like databases and everything. So if you bring everything together and you have weighted contributions, then you can ask questions, and the twin would make decisions for you, and it will tell you which direction to look at. And that's one of the solutions that we are trying to explore. And in general, like neural networks is something that might be more effective to use here than other types of interconnecting systems. So yes, that's a really good question, and hopefully it will pan out at some point. It's very, very hard to achieve.
Thank you, Greg. And this is more general, I guess, because Tony alluded to the difficulty of finding a biomarker of disease activity. Can you, for both of you guys, can you comment why it's been so hard to do that? And, secondly, if you had one available, what would be the first study that you would do? And let's start with Tony.
Yeah, it's a good question. We have a genetic disease, and so unlike other conditions, we can start like from young patients and get samples. I think it's just because the disease there's no specific inflammation or any type of specific dynamic that leads to inflammation that we could measure. The first study I'd like to do is well, there are several. For the patients, I know they always ask me this. I'd love to do a vegetarian diet and see what that does, or a Mediterranean diet. And then I'd like to look at losartan or other ARBs to see. And that would be just so great if we could just start with basics like that.
Thank you, Tony. And Greg, any comments?
Well, just I just want to say that it's a really important part of what we are trying to succeed here, to find robust biomarkers that go beyond diagnosis, but also can be used in trials as well. Some things that change. So if we have access to samples, access to data, then that makes our life much easier. And we're very thankful to our patients here in Cyprus. They are very responsive and very involved. And we are very keen in keeping this collaboration that we have, because it's really, really hard to identify something that makes sense and that works in the hands of everyone. So just a big thank you going out to patients for their support.
Yes, if I could just say something too, I should have mentioned that first. Yeah, the patients are just so important. And so every data point is a patient, right? And every point brings us closer to where we need to go. And when you have a rare disease, like Greg is saying, every single patient just helps us with this.
Yeah, especially now that we're living in the era of personalized medicine, which means that each patient can basically act of their own control, and the patient itself can provide the information of what is needed to be provided as a therapeutic intervention, or how things are measured. I mean, everyone is quite special to have their own mechanistical aspects that signify how the disease behaves. So that's quite important. And a rare disease brings us along this type of data sets that are patient specific, and that's really important for us, but also hard to manage.
Thank you, Greg. And yeah, I want to say, wonderful talks and, sessions, and this is really, how the PKD field started, right? 25 years ago, people were kind of doing their own thing, collecting data. And I think it's important that people are talking to each other, creating this databases that can be leveraged. Ideally, moving forward to federated analysis, where we can look across different registries and databases for different, biomarkers, disease patterns, etc. And this is how, a field matures, and you get to a prognostic biomarker or a drug response biomarker, and that's where the pieces come together the way they have for ADTKD, where TKV now can be used as a primary surrogate endpoint, or reasonably likely surrogate endpoint. So yeah, very grateful to be part of this community.
Thank you so much, Sorin. We're going to have to move on, but thank you, Sorin and Tony and Greg, for this really important and forward-looking presentation. So we're very excited. Thank you.